Yeah.
Yeah. So I'm giving some of my small tips in SICS surgery. Now, whenever I do the peritomy and the cutting of the tenon, immediately after the cut, I infiltrate fluid under the conjunctiva. This fluid can be BSS, or if you want, you can inject anesthetic. So I form a bleb under the conjunctiva. So after the tenon also is cut, again I form another bleb under the tenon. Now, the advantage of forming a bleb is that whatever bleeding takes place during the from the sclera, the blood cannot enter the subconjunctival as well as the subtenon space. So this way, postoperatively, cosmetically, the eye looks comparatively good because there is no red eye or subcanal hemorrhage like picture. So this is a tip to prevent blood entering into the subconjunctival and subtenon space. Infiltrate with BSS or infiltrate it with anesthetic. So this is my first tip. So you can see the bleeding, but which is coming out and not entering the subconjunctival space. So your conjunctiva remains quite clean. I do all the surgeries under AC maintainer. So here I'm putting the AC maintainer and see the side port. This is, I call as a half side port. This is not a complete width side port. Initially, very small entry is made. It is the MUR blade is not totally passed. The advantage I'll tell you when I do the capsular excision. Now, whenever the incision is taken, in your mind, I know the shape of the incision and I straightway start the dissection. Most of the surgeons generally they form the initial groove, but here I start the dissection straightway with the crescent knife. So there is dissection without groove. The advantage of this is that the overlapping of the edges is so fine that postoperatively you don't come to know about the wound, or at the most you can see that there is some only 2 mm dissection done. So the eye looks very good and you cannot make out the incision. So cosmetically it looks very good, but in the mentally you have to form the picture of your shape and start dissecting. Now I talked about the half side port. So when there is a half side port, you can do beautiful capsular excision. You can see that there are no folds in the cornea. The needle is easily passing through, but still there is no turbulence of fluid. The AC maintainer is on. This is done without viscoelastics. So you can have a very totally closed chamber, perfect capsular excision with that half thickness of the side port. So when the capsular excision is done, then I do the proper side port with MUR blade, totally entering the MUR blade through the same incision. So this helps us in a good capsular excision. Now this needle also I am doing under AC maintainer. So the capsular excision needle is mounted at the back of the Sinsky hook because there is no irrigation. Just hold it like a pen and your irrigation is coming through the AC maintainer. Now this is my technique of multiple rotation of the nucleus. Even if you feel that the nucleus is free, you rotate it multiple times clockwise as well as anti-clockwise. The advantage of this is that you free the cortex from the capsule, and the capsular polishing also take place. Recently, I've seen Dr. Neto Roselli's video, that is, he calls it a nuclear spin. Now, this is my technique of endoexpression. Whenever the nucleus is stuck into the tunnel is small one, AC maintainer is on, you are working in a deep chamber. So with the Sinsky hook pass through the side port, I try to push the nucleus. So the nucleus will either stretch the sclera, come out totally, or it can get fractured into the scleral tunnel. So the friction is into the walls of the scleral tunnel and not the endothelium. This technique is called the endoexpression of the nucleus. Whenever you are doing the capsular polishing with the AC maintainer on, to prevent shallowing of the AC with the forceps in the left hand, generally I narrow the tunnel. So only to 2 or 3 mm opening, the polisher is passed. So this helps in a very good capsule excision. And when you are putting a rigid lens with the AC maintainer on, the moment you leave the forceps, the lower haptic hits the cornea. So you have to always support the upper haptic with the forceps in the left hand. So this way, the lower haptic remains in the capsular bag whenever you are doing implantation with the AC maintainer. So these were my 4 to 5 tips in the SICS surgery.